Infectious diseases cause significant morbidity and mortality, especially in some individuals who are most vulnerable to illness. For example, the very young, the elderly, and the immunocompromised. The pathogenesis of infectious diseases depends on and reflects the relationship among the human host, the infectious agents, and the environment. The infectious agent can be either exogenous or endogenous. Infection results when an exogenous agent enters the human body, it is introduced into the host, or when an endogenous agent overcomes host immunity to cause disease. So, the host susceptibility plays an important role in either of these settings. The environment includes two main factors, vectors and zoonotic hosts or reservoirs. Vectors are most commonly insects, but also other carriers that transmit infectious agents to the host, or zoonotic hosts, reservoirs, usually animals harboring infectious agents and often acting to amplify the infectious agent. For example, the Lyme disease is caused by a bacterium, Borrelia burgdorferi, living in a reservoir in a host. This is the white-footed mouse, a mouse. The infection in the mouse is usually asymptomatic, thus the bacteria can multiply to high levels. When an insect larva, the tick larva, this is the transmitting agent, when the larva feeds on the infected mouse, it becomes secondarily infected with Borrelia burgdorferi, and the infection will persist when the tick molts into a nymph. Subsequently, a nymph will feed on a human, thus the bacterium is transmitted to a host, causing the disease, the Lyme disease. Let me note other mouse or insects also may do the same to serve as hosts and vectors for the Lyme disease and for many other infectious diseases. In addition, the development of a disease into the host is also related to some population factors. For example, the interactions in the Society for the Tuberculosis. For example, tuberculosis may occur in homeless shelters, in prisons, bars and nursing homes when an index case comes in close contact with susceptible persons. Individual characteristics of the host, from organ level to genetic, cellular and genetic level, also play a defined role. Let's now consider the host defenses against infection. We are protected by physical barriers, for example, skin and mucosa. When these barriers, their physical defenses, are breached, the immune system is activated. First, the innate immunity is starting to fight against the initial infection. It includes preformed proteins, for example, complement, and some cells, phagocytes, that are activated by non-specific foreign proteins, thus generating an immediate response to foreign material. This is the innate immunity. The infection being caused recognition by preformed non-specific effectors and removal of the infectious agent, or after a response induced, it is early response, the infection will cause recruitment of more effector cells, followed by recognition and activation of effector cells and removal of the agent, or a late adaptive response. The infection may be followed by transportation of the antigen in the organism, for example, to the lymphoid organs, to be recognized by B and T cells and after clonal expansion and differentiation of effector cells, a removal of infectious agent will be performed. This is during the initial infections, the first entry of the specific infective agent into the body. Every subsequent entry of the infectious agent, the reinfection, will activate our specific, our protective acquired or adaptive immunity. The reinfection will cause a recognition by the preformed antibodies and T cells, effectors, to attack, to counterattack, and to remove the infectious agent. And in addition, immunologic memory is activated during the reinfection, thus recognition by memory B and T cells is performed, and rapid expansion and differentiation of effector cells will cause rapid removal of the infectious agent. We are thus protected by our specific immunity. Our body normally harbors numerous species of microorganisms, bacteria, viruses, protozoa, fungi. The great majority of these are commensal bacteria, known also as normal flora. They are defined as organisms living symbiotically on or within the human host, but only very rarely causing diseases. If you check the skin surface, you will find usually staphylococci. In the oropharynx, streptococci are found. In the large intestine, enterococci are present, and lactobacilli in the female vagina. Commensal bacteria usually do not cause infections. Instead, they are living symbiotically in our gut, for example, as shown here. They are releasing products able to bind to our specific receptors for microbial products. These are the toll-like receptors. The products released by commensal bacteria are the ligands of toll-like receptors. The interaction achieved, this is the component of a signaling pathway which is absolutely necessary to maintain the normal homeostasis of the intestinal surface, as shown here, and also to ensure a repair in response to an injury. The basal signaling may be compromised if the binding of the ligands to the receptor is prevented, and as a consequence, an enhanced sensitivity to injury and also a reduced capacity to induce repair will be observed. The same is true for the full lack of signaling. It is observed, such a condition, usually after treatment by a powerful antibiotic, eliminating the infectious agents together with the commensal bacteria in the intestine. That's why it is recommended to take simultaneously with the antibiotics cultures of commensal bacteria to prevent the disorders. Usually a diarrhea is produced during long term of antibiotics at high doses. At some occasions, however, commensal bacteria will induce infection. For example, Candida albicans may cause infection, and other microorganisms also, in immunocompromised patients. For example, AIDS patients. These infections are termed opportunistic infections. When the symbiosis between the commensal bacteria and the body is disturbed, the normal flora may be overgrown by either exogenous or endogenous organism. This is known as colonization. This is not yet a disease. However, if later invasion of tissues will be realized by this microorganism and abnormality will be induced, this is already an infection. If the replacement of the normal flora occurs in hospital environment, the colonizers are said to be nosocomially acquired, and the infection is known as nosocomial infections in hospital environment. The constitutive defenses of the human body include, for example, physical barriers, the skin, and chemical barriers, for example, acid gastric secretion. These barriers will prevent easy entry of microorganisms into the body. Mechanical clearance, for example, by the urine flow, plays also a defense role. Let me note, however, that the gonococci are able to adhere to mucosal epithelium, thus to evade from the mechanical clearance, the washing with the urine flow. The mucus on the mucosal membranes and the enzyme, for example lysozyme and peroxidase, released on the mucosa also play an antimicrobial role with antimicrobial activity. Another non-specific defense, this is the inflammatory response after a breach into the barrier function. For example, inflammatory hyperemia and systemic neutrophilia optimize the delivery of phagocytes to the site of infection, where pathogens reside. Inflammatory mediators are released, cytokines, that will play a role as pyrogens to increase the body temperature to produce fever. The fever response may inhibit viral replication and also to decrease the proliferation of bacteria, of pathogens. In addition, the proliferation of bacteria is suppressed by the iron deficiency caused by the elevation of the body temperature in fever. However, when the inflammatory responses become extreme, extensive tissue damage may be produced, may result as observed in sepsis. We'll comment that later. Let me note the special role of the complement system. It is activated during the inflammation and may play an important role in the response. It is activated, for example, by the formation of immune complexes or by microbial surfaces contact in the alternative pathway activation. Some components of the complement system are especially important. For example, the C3b component. It is responsible for the opsonization and facilitation of the phagocytosis, destruction of infectious agent by phagocytosis, while the C3a and C5a are responsible for the recruitment of more inflammatory cells. And finally, the C5b to C9 complex, this is the so-called membrane attack complex responsible for the cell destruction. This complex is attacking the membranes, the walls of the infectious agents, and it is destroying them. The last important innate defense system to note, this is the phagocytosis. It is performed, for example, by polymorphonuclear leukocytes. They are recruited by hemotaxis and they are acting after the opsonization. The engulfed bacterium or foreign particle in general will form a phagosome. The phagosome will be destroyed by formation of phagolysosome fusion with a lysosome. The enzymes and the oxygen species into the lysosome will destroy the bacterium. I will discuss briefly some abnormalities. For example, the neutropenia, a decreased counts of polymorphonuclear leukocytes. It is related with increased susceptibility to bacterial and fungal infection. This may be observed in some blood disorders causing neutropenia. Another disorder of the phagocytosis, this is the Chediak-Higashi syndrome. Because of genetic defects, no fusion of phagosomes and lysosomes is observed, so the engulfed bacterium may survive. Or, because of another genetic defect, the production of reactive oxygen species may be compromised. This condition is known as chronic granulomatous disease. It is characterized by chronic infections, granuloma formation, caused usually by Staphylococcus aureus or Aspergillus. We already commented with details the induces defense. The previous lecture we presented the immune responses, so I will not pay more attention to present details. Now, the establishment of the infection, which are the components of this establishment. First, the microorganisms must encounter the host to realize a contact. Let me remind the role of the insects and other transmitter, the vectors. Later, they need to gain entry into the host, to multiply locally and to spread from the site of the entry, and finally to cause host tissue injury, either directly, for example by releasing some specific substances, cytotoxins among others, or indirectly, for example the host inflammatory response. Let me remind which are the characteristics of the chronic inflammatory response. In this response, the recruitment of macrophages is related to release of inflammatory mediators acting to destroy the intruders, which are the weapons of our inflammatory cells. They are releasing, for example, reactive oxygen species, lysosomal enzymes, membrane attack complexes formed. All these factors will contribute to the destruction of the infectious agent, however, together with the destruction of the own cells. So damage to the host by a chronic inflammatory response also may be observed. This is the reason to apply in some chronic diseases anti-inflammatory treatment, thus to prevent the damage of the organism by a chronic infection. Let's now consider the possible outcome of an infection. For example, resolution may occur by eradication, destruction, and elimination of the infectious agents, or a chronic active infection may develop. For example, in acquired immune deficiency syndrome, there is a chronic active infection and a chronic disorder for years. The next opportunity, this is a carrier state. This is the case with a prolonged asymptomatic excretion of the agent. The most common example, this is the salmonella. Latency of the agent within the host may be observed. Typically, this is found in tuberculosis cases or varicella zoster virus infections. And finally, the outcome may result in the death of the host. Bypassing the usual chemical and physical barriers occurs via penetration. Penetration may occur when, for example, an insect vector directly inoculates the infectious agent into the host, for example, mosquitoes transmitting malaria, or bacteria may gain direct access to host tissue through loss of integrity of the skin or mucosa in trauma or in surgical intervention. Or finally, microbes gain access via instruments or catheters that allow communications between usually sterile sites and the outside world, for example, undwelling venous catheters. In contrast with the penetration, The ingression occurs when an infectious agent enters the host via an orifice contiguous with the external environment. For example, inhalation of infectious aerosol droplets for Mycobacterium tuberculosis, or for example, ingestion of contaminated foods, Salmonella, hepatitis. Let me note that some infectious agent may directly infect mucous membranes and cross the epithelial surface to cause infections. This commonly occurs in sexually transmitted diseases. Once introduced, infections can spread along the epidermis in impetigo or derma, in erysipelas, along the subcutaneous tissues. In cellulitis, we already considered the cellulitis. This is the generalized inflammatory response. Also along fascial planes or along the muscle in myositis, along the muscles. Along the vessels, veins, thrombophlebitis is caused, and lymphatics, lymphangitis. Spreading may result also by the penetration into the blood. The blood is carrying bacteria or viruses, bacteremia and viremia. And finally, organism may spread into an organ in pneumonia and hepatitis. The next step in the infectious process, as already noted, this is the injury to the host. It may be due sometimes to a pure mechanical obstruction, as observed in small children, bowel obstruction in gastrointestinal infections. More commonly, however, the injury to the host is the secondary result of an inflammatory response. We already discussed the mechanism of damage during the inflammation of local cells, local tissue, by the release of mediators such as enzymes, reactive oxygen species, membrane attack complex, among others. Some bacteria release neurotoxins and cytotoxins. Neurotoxins, for example in tetanus, do not cause cell damage. Instead, tetanus toxins antagonizes inhibitory neurons, causing unopposed motor neuron stimulation manifested as muscle rigidity. Host cell death can occur by another mechanism, production of cytotoxins. It will cause death, for example, of enterocytes as a consequence of Shigella invasion. Shigella is releasing cytotoxins. Another toxic product released by infectious agent, this is the endotoxin production, released from the gram-negative bacteria. It will initiate a cascade of cytokine release, resulting very often in sepsis syndrome and even septic shock, as will be commented later. Let's now consider examples of infectious disorders. For example, meningitis. The clinical presentation of meningitis includes fever, headache, especially neck stiffness, the meningismus, and also confusion and photophobia. The specific finding from the labs, this is the cerebrospinal fluid leukocyte pleocytosis. This is the hallmark of the disease. In adults, the meningitis is caused usually by Streptococcus pneumoniae and less commonly by Neisseria meningitidis. They are both capsulated bacteria. In neonates, in babies, the meningitis is usually caused by group B streptococci. because of the vaginal flora translocation of microorganisms during the birth, during the parturition. In children, the most common causes are Streptococcus pneumonia, as in adults, but also Neisseria meningitidis. Now, the pathogenesis. First, the colonization. It is achieved on the mucosal epithelium of the nasopharynx. Let me note that the Streptococci secrete an immunoglobulin A1 protease. This is an enzyme degrading the host defense, the antibodies, inactivating the host antibodies. This allows the bacterium to bind freely to host receptors on the epithelium and to colonize, and later to penetrate through the mucosal epithelium into the bloodstream. Usually, a bacterium penetrating into the blood will be destroyed by phagocytosis by our macrophages. However, as already mentioned, these bacteria are capsulated, so the capsule will prevent the interaction between the opsonine, this is the C3b component of the complement system, and the phagocytic receptors, so thus the Streptococci will evade the phagocytosis. Thus they may cross the blood-brain barrier and to penetrate into the subarachnoidal space. There they will cause inflammatory response. This is due to the expression by the bacteria of ligands to the receptors on the blood-brain barrier, and after binding they are able to increase the permeability of the blood-brain barrier, thus to penetrate easily into the cerebrospinal fluid. The inflammation caused into subarachnoidal space will be followed by release of inflammatory mediators. For example, interleukins 1 and 6, tumor necrosis factors, and also enzyme metalloproteinases. This slide summarizes the complications of the meningitis. For example, the inflammatory reaction will be related to more severe blood-brain barrier disruption and generation of a state known as hydrocephalus, and also cellular edema, cellular swelling. So a cerebral edema may be causing both disorders, functional disorders, such as metabolic disturbances with acidification, vasodilation, elevated pressure, intracranial pressure may increase, intracranial pressure may even cause cerebral herniation, and also the inflammatory reaction may affect the function of the vessels. Vasculitis will compromise the blood perfusion. The cerebral ischemia may be produced together with the cerebral herniation. As you can see, all these complications are too severe. They are too severe. Pneumonia is the next example of infectious disorder to consider today. Pneumonia represents an infection of the lung tissue resulting in inflammation of the lung parenchyma and accumulation of an inflammatory exudate into the respiratory passageways. The etiology is complicated. In about 50% of all cases of pneumonia, no causative agent is identified. The microbial diagnosis may be delayed by several days in many cases. Anyway, the most common microorganism related to the generation of pneumonia is the Streptococcus pneumonia, also influenza virus and cytomegalovirus. Let's now discuss how are the bacteria and viruses able to produce inflammation of the parenchyma. They have to enter respiratory passageways to penetrate into the parenchyma and to cause the infection. Are we defenseless? No. First, let's consider the passageways. This is here the mucosa of the respiratory passageways, one cellular layer of respiratory epithelium equipped with cilia and producing mucus, which is the function of the mucociliary apparatus. Mucus is capturing bacteria, viruses, small particles, dust, and the cilia are moving outside all these captured elements. So the function of both cilia and mucus is important. Any dysfunction compromising the mucociliary blanket function will be related to penetration of bacteria into the alveoli. How is it possible? Is it possible to eliminate somehow the cilia? Yes, this is fully possible, for example, due to metaplasia in smokers. In smokers, the inhalation of tobacco smoke, because being irritative, will cause metaplasia of the epithelium, thus converted to multicellular layer with no cilia. This is a protective reaction against the chemical compounds in the tobacco smoke. So, in smokers, the mucociliary blanket function is compromised, bacteria will be retained and may penetrate the alveoli. They are here. However, we have other defenses into the alveoli. Alveolar macrophages are penetrating and residing there, and also antibodies and complement system components such as opsonins are penetrating antibodies and complement system components. So the bacteria in our alveoli will be attacked by the alveolar macrophages and by antibodies. However, is it possible to produce some suppression of these immune defenses? Yes, of course, in immune deficiency disorder, especially in AIDS. Let me remind, almost the half of the AIDS patients are dying because of pneumonias. These are the typical cases of opportunistic infections in immunocompromised patients. So finally, both the parenchyma, the alveoli, and the passageways will be affected, which are the consequences from the inflammatory response. Fever, of course, cough because of the abundant mucus formation, and changes into the respiratory and cardiovascular system, tachypnea and tachycardia. If you check the chest by X-rays, you'll find infiltration somewhere into a lobe, less or more generalized. The next type of infection disorders to consider today are the diarrheas. Let's first define diarrhea. Diarrhea is a condition characterized by increased stool frequency, increased stool volume, and decreased stool consistency. Which is the normal stool frequency? Usually the defecation rate is about once per day. 2 times per day is still normal, and 3 times per day, this is already marginal. More than 3 times per day stool frequency, this is sure, this is a diarrhea. Increased stool volume. The normal stool volume is too small, several hundred of milliliters. For example, 1, 2 to 400 maybe milliliters. In diarrheas, it is strongly increased, several liters per day. How is it caused? 2 main mechanisms: increased secretion into the intestinal lumen, or decreased absorption by the intestinal epithelium, thus increasing the end content of the intestinal lumen. Which are the causative agents? Viruses, for example the rotavirus, especially in children. Bacteria, for example, this case here, cholera bacterium, but also fungi, protozoa. They may be either waterborne or foodborne or transmitted person to person. The pathogenesis, as already noted, either secretory or inflammatory malabsorptive diarrhea. This is an example of secretory diarrhea shown here. The cholera bacterium will release, after binding to the cell membrane of the enterocyte cell membrane, a toxin, especially the B subunit of the toxin, binding to the enterocyte surface will cause an increased activity of the adenylyl cyclase by activating G proteins into the membrane and thus activating some channels across the membrane. The activated channels in cholera are chloride channels, so chloride is actively transported and secreted into the intestinal lumen. It is followed osmotically by water. A lot of water will enter the gut lumen. This is a watery diarrhea. The volume of the stools may be 3 to 7 liters per day. So, which is the consequence? One among the main consequences of the diarrhea: severe dehydration. Good. This is the secretory diarrhea. Example, cholera. Now the other example. Remember me, which is the main function of the enterocyte into the intestine. Of course, this is the absorption. They are absorbing. So, every inflammatory disease affecting the lining of the damaging the enterocyte will result, this is the hallmark of the inflammatory disorder, loss of function, loss of the ability to absorb, decreased absorption, and increased amount of fluid into the intestinal lumen. In the inflammatory diarrhea, stools may contain mucus, and in some more severe cases, for example, caused by Shigella, even blood and leukocytes may be present into the feces. This is known as dysentery. In the hemorrhagic diarrheas, let me note this one caused by enterohemorrhagic Escherichia coli. It produces two toxins binding to the cell surface receptors, the A subunit of the toxin catalyzing the cleavage of ribosomal RNA and halting the protein synthesis, causing cell death. This is especially a more severe hemorrhagic diarrhea, a severe dysentery. The clinical consequences of diarrheas include upper tract, gastrointestinal tract signs, for example, nausea and vomiting together with pain, epigastric pain. The small intestine signs, this is the watery diarrhea. If large intestine is affected, some other signs will be present, for example, the fecal urgency, the bloody diarrhea, and the tenesmus, the painful contraction of the smooth muscles of the large intestine. The general finding is fluid loss, dehydration. In severe cholera case, the fluid loss may be about 1 liter per hour. Severe dehydration with hypovolemia, hypotension, collapse, and even death. Now, the sepsis. The sepsis is not a disease. It is a clinical syndrome characterized by a dysregulated inflammatory response to an infection. Its incidence rate is not too high. However, the fatality rate, the mortality rate, is about 50% in severe infection disorders. The rate of sepsis continues now to rise because of the increased use of some manipulations and instruments such as catheters, especially intravascular catheters, implantation of prostheses such as cardiac valves, artificial joints, and also the administration of a lot of immune suppressive drugs. So the sepsis will present as a continuum of conditions from infection and bacteremia to sepsis and septic shock. All these components may be found together into a patient. The modern definition of the sepsis is as life-threatening organ dysfunction caused by a dysregulation of the immune response to infection, including the dysregulation of the inflammatory response. And another term, the septic shock. The shock represents a subset of sepsis characterized by profound circulatory change followed by cellular and metabolic abnormalities, and especially associated with a greater risk of mortality. The basic characteristic of sepsis, this is the blood-borne infections, most commonly bacteremia and less commonly fungemia, parasitemia, viremia or other. So let's now differentiate between the sepsis and another term used in the medicine, in the medical practice, SIRS. This is the systemic inflammatory response syndrome. This is another syndrome which represents a form of dysregulated inflammation seen with both infections but also with non-infective disorders, such as some inflammatory disorders, pancreatitis, burns, trauma, and some other conditions. So, the syndrome of systemic inflammatory response syndrome may be present together with the bacteremia or may be present without bacteremia. These are different conditions. The syndrome may include change into the counts of white blood cells and change into the body temperature. How is sepsis caused? The site of infection may vary: respiratory tract, genitourinary tract, abdominal area, for example, gallbladder or colon, also wounds and some implanted devices. Usually, bacteria is caused, and bacteria will later release toxins. Usually, bacteria most commonly are Staphylococci and Escherichia coli. Less commonly, fungi are present. Bacteria, especially gram-negative, this is the example to be considered, release toxins, endotoxin. Endotoxin will bind to the receptors. Remember me, which are these receptors? These are the toll-like receptors. After binding to the receptors, the LPS, the lipopolysaccharide, this is the synonymous term for endotoxin, will activate a cascade of events intracellularly, finally producing high levels of nuclear factor kappa B. The nuclear factor kappa B is a transcription factor activating the production and release of cytokines by macrophages and other inflammatory cells, mainly leukocytes, and especially the interleukin-1 is released together with interleukins 2, 6, and so on. Also, interferon, tumor necrosis factor, and platelet activation factor. Which is the function of all these cytokines. First, they represent pyrogens. They are reaching through the circulation the hypothalamus. This is the anterior area, especially the organum vasculosum of the lamina terminalis, expressing receptors for interleukins and other pyrogens. The response is fever, with accompanying changes such as tachycardia and tachypnea. So, fever is present in sepsis. Other effects, other consequences. Effect on capillary endothelial wall. Which is the effect? Recruitment of neutrophils, margination because of activating of endothelium, expression of selectins, and release of ICAM, intercellular adhesion molecule. So, neutrophil margination and platelet adherence. Which is the consequence from the platelet adherence? Platelet aggregation and activation and release of coagulation factors. Activation of the coagulation system. Which is the consequence? Local thrombosis, and after consumption of the coagulation factors, even hemorrhages. This is known as DIC, disseminated intravascular coagulation syndrome. Because of the damage to the endothelium and the increased permeability of the endothelium, fluid loss, depletion of intravascular volume. This will cause hypotension, decreased blood pressure, and decreased perfusion of the periphery. In the tissues, cellular hypoxia will be observed. Hypoxia, this is a term related to the decreased oxygen consumption because of the depletion of the intravascular volume. So, the hypoxia, energy deficiency, and also toxic radicals, active radicals release. Which is the compensatory reaction to the cellular hypoxia? Another source of energy, oxygen deficiency, anaerobic glycolysis will be switched, and production of energy will cause accumulation of lactic acid. So, lactic acidosis, this is the end stage of a patient with a sepsis. Every patient suspicious for sepsis should be checked for the presence or absence of lactic acidosis. This is a severe state that may cause death, but anyway, multi-organ dysfunction due to the cellular hypoxia is present. Myocardial dysfunction, pulmonary dysfunction, renal and hepatic. And in addition, there is a formula. The fatality rate may be about 50%. Now, it may be even more severe. Any other system involved. Cardiovascular will add 10% more. Pulmonary, renal. For example, a patient with myocardial dysfunction and pulmonary dysfunction, this patient mortality rate will be about 70%. Good. This is the picture, the mechanism of the sepsis. Now, let's summarize the sepsis and the septic shock. These are here the infectious sources, and the condition will depend, as already noted, on the location of the first site of infection, on the nature of the infective agent, its virulence, on the load, on the dose of the infective agent inoculated, and also host factors, genetic, immunocompetence, and eventually other present diseases, comorbidities. All these factors will contribute for two main responses, as already know. We discussed immune responses together with inflammatory response and coagulation response. The inflammatory response will be related due to the release of a lot of cytokines to cardiomyopathy, vasodilation with decreased blood pressure, hypotension, also increased vascular permeability, loss of intravascular volume, severe hypovolemia, contributing and potentiating the hypotension, and finally causing a shock, an extremely low perfusion, hypoperfusion of vital organs. The coagulation response, as already shown previously, will cause microvascular thrombosis. They will both potentiate the increase in vascular permeability and also contribute for the tissue hypoperfusion and for necrosis observed, cell death. Let me remind, necrosis is always causing inflammatory response due to the release of intracellular contents acting as inflammatory mediator. So, this factor will potentiate the inflammatory response to cause a vicious cycle to multiply the response. So, both the tissue hypoperfusion and the hypotension, the shock, will cause organ failure and eventually death. Survival is relatively rare in shock, especially septic shock. Let me note some extremely important components of the sepsis and septic shock: the intravascular events, the Dick syndrome, disseminated intravascular coagulation, and especially the organ failure, for example, in the respiratory system due to the endothelial injury of the pulmonary epithelium, the acute respiratory distress syndrome. In general, clinical manifestations are related to the systemic responses to infection: tachycardia, tachypnea, fever, and alteration in the leukocyte counts, and also related to specific organ dysfunctions. This is the picture of the septic shock. At the end and out of the program, some words about the actual epidemic, the infection with the COVID virus. The COVID virus, coronavirus 19, this is the picture of the virus. Let me note especially the spike glycoprotein. The spikes are related to the binding of the virus. It is binding to a receptor site angiotensin converting enzyme type 2. This is a normal component of the renin-angiotensin system. This is the enzyme converting the angiotensin 2, the hypertensive component, to angiotensin 3, the hypotensive component, by vasoconstriction here, vasodilation here. Anyway, it binds and penetrates the organism through the angiotensin converting enzyme type 2 site. So, after entering the cells, it initiates a cascade of events finalized by the stimulation of the nuclear factor kappa B. As already noted, this is a powerful transcription factor causing stimulation of cells, here macrophages, T cells and neutrophils, to produce and to release cytokines. The main cytokines are noted here: interleukins 1, 2 and 6, and tumor necrosis factor alpha and interferon gamma. A true cytokine storm releasing a powerful inflammatory cascade, and this disordered response causing acute respiratory distress syndrome, as already mentioned, and sepsis with multi-organ dysfunction syndrome causing death or tissue damage with dysfunctions of all these organs, mainly lungs. Usually the main disorder in infected patients, this is the respiratory system affection and a severe pneumonia. And the second one, let me note, coagulation response, microvascular coagulation and thrombosis. A lot of patients with COVID virus infection will die because of severe intravascular thrombosis. This is the summary of the infective process. Viruses penetrate mainly under the form of respiratory droplets through the upper respiratory tract, nasal cavity and pharynx, but also by contact. So we need to wash our hands. Later, it penetrates the lower respiratory tract, but also gastrointestinal mucosa may be affected. In children and young people, the viremia is moderate, so asymptomatic patients, a lot of asymptomatic patients may be present. They are, however, extremely dangerous because, if not isolated, they will cause reinfection of more persons. So, the consequence, overactivation of T cells, immune dysfunction together with overproduction of inflammatory mediators, cytokine storm, acute respiratory distress syndrome, and death. This is the typical sequence of events in COVID-19 infection. Is it possible to treat less or more specifically? For now, no, there is no specific medicine for this virus. However, the cytokine storm may be influenced, for example, by giving interleukin receptor blockers or inhibitors or chemokine receptor blockers. Also, inflammatory mediators inhibitors such as platelet activating factor inhibitors or cyclooxygenase inhibitors. This will cause regulation and modulation through inhibiting of the cytokine influx to restore the immune homeostasis and the normal release of cytokines. This is one approach. The other approach is to elaborate on vaccines. We are now starting the mass immunization by the first vaccines. Let me note, we have to be very careful. Look here, this is a list of the complications till now described. As you see, they are too much and they are too severe. Encephalomyelitis, transverse myelitis, encephalitis, stroke, anaphylaxis, myocardial infarction, and so on. They are arranged in the order of the incidence. The higher rate is this one of the Guillain-Barré syndrome, followed by the encephalomyelitis, transverse myelitis, and so on. So don't forget that. That's all for today.